Hi everyone, welcome to Talking Life with Mei Sze, and for returnees, welcome back to Talking Life with Mei Sze, a podcast centered on health and wellness. In conjunction with Colorectal Cancer Awareness Month, we are going to talk about the modern advances for colon cancer treatment. So today's episode is focused on colorectal cancer patients who are currently undergoing treatment, and of course, for those of you who were recently diagnosed. We hope that we can provide a lot of information to you through today's episode. And as you all may know, if you follow me, I'm a colorectal cancer survivor. So this topic is always close to my heart, and I always believe in advocacy. Why? Because let me share with you a little bit more about the statistics. But before that, I would like to ask you to share this with your friends, with your family. Get them to tune in to find out more about colorectal cancer. And also, if you have any questions, for those of you who have never been on the show, you can put them in now because we'll try to answer as many questions as possible towards the end of the show. Now, where does the colorectal tract encompass? It basically encompasses the colon and the rectum, which means you can get cancer in your colon or in your rectum. For example, I'm a rectal cancer survivor. So the cancer happened in the rectal area. And for colorectal cancer, it is globally the third most common cancer and the second leading cause of cancer deaths at 10%. 1 in 23 men have a lifetime risk of colorectal cancer and 1 in 25 women. The statistics sounds bleak, but don't worry because we've also found out that the 5-year survival rate, if your colorectal cancer is detected early, is 90%. That's huge. Versus if you detected it late, it drops to 15% or so. So the difference is stark when you talk about the numbers. So the most important part is to go for screening. And if you have genetic history, you need to go for screening and find out how to. I think this month, there's a lot of information on how to screen. That's why we want to focus on all the modern advances that is available for colorectal cancer and the hope and healing out there. We want to give you hope. And during this time, please share this live with your friends and family on YouTube or Facebook. Get them to tune in. And more importantly, if you have questions, you can put them in now. I would also like to introduce our two esteemed doctors who have years of experience. We have Dr Aktbar, who is a colorectal surgeon with Sanjal Medical. Hi, doctor. Thanks for coming on the show. And we have no stranger to Talking Life with Mei Sze, Dr Jenson, who is a clinical oncologist at Curie Oncology. So you've met him before. Thank you for coming back on the show. So like I said, we're going to dive into colorectal cancer right away. So I'm going to start with the questions. If you have questions, you can put them in now. So Dr. Qureshi, my first question for you is, for someone who have been diagnosed with colon cancer through a colonoscopy, the dreaded colonoscopy, what is the next step or approach from a colorectal surgeon?
Okay. Once you've been diagnosed with colorectal cancer, then what will happen is that you will have blood tests done, okay, and you will have what we call imaging done. So the blood test is primarily to ascertain the level of hemoglobin. That means make sure that you haven't lost too much blood from your cancer, making sure that you don't have any other issues such as kidney issues or liver issues. And then of course the imaging. Imaging in terms of colorectal cancer is primarily either a CT scan or an MRI. Now, the idea of this imaging is to look at the cancer that was found at colonoscopy. Now, what the colonoscopy does is that it looks at the cancer from within. So if you imagine you're in a tube, you're only looking on the inside. You don't know what's happening on the outside. And that's where the imaging comes in. And the imaging then tells us whether this tumor is limited to the bowel wall, or has it breached the bowel wall? Has it involved the lymph nodes? Does it affect the liver or the lungs? And so when I get a patient like this, so we get the imaging done, And when with that imaging, I will then have a discussion with my good friend here, Jenson, together with the radiologist, and we each and every patient is discussed in depth in relation to the findings, and then we set out a plan for the patient. So, for example, for patients with a rectal cancer, some of these patients would require radiotherapy before surgery, and again, that is a discussion. It's not just a one-person decision. It's actually a team, what we call a multidisciplinary effort. Okay,
Yeah.
so then if the patient requires radiotherapy before surgery, then we would discuss the pros and cons of either a short course or the long course. And again, it's an in-depth discussion before we proceed to surgery. Now, so generally speaking, nearly all patients with colorectal cancer will have some form of surgery. And the surgery entails removing not just the cancer, but a good margin on either side, okay? So above, below, and surrounding. So, and to make sure that you've got the tumor with clean margins, as well as the lymph nodes that are associated with that tumor. And then once that has been sorted with the report, then again, the oncologist comes in, and then we make a decision as to whether additional treatment may be required. So where if the treatment is given beforehand, we would call it neoadjuvant treatment. But if it's done afterwards, we call it adjuvant treatment. And then, of course, Dr. Jenson, will then have in-depth discussion with the patient based on that report as to whether or not adjuvant treatment is required, because that report will tell us about the staging of the tumor. One additional imaging that is done for a number of patients, and usually the oncologists will ask for this. It can be done before or after surgery, is the PET scan. Okay, and a PET scan essentially scans the entire body, okay, to look for potential sites of spread of this tumor. So, for example, lungs, liver, bone, and anywhere else. Okay, and it's a fairly good assessment for spread.
Thanks for the detailed information. So if you were diagnosed through a colonoscopy, you can go for you go for imaging and blood tests after.
Yes.
So that is the next step for
Precisely, yeah.
colorectal cancer patients who are recently diagnosed. Now, Dr. Jenson, we were talking about the stages Dr. Qureshi mentioned. So if someone has already been diagnosed with early stage colon cancer, how would you then approach them in terms of further therapy? Because I think Dr. Qureshi mentioned that it's either adjuvant or neoadjuvant, or sometimes is surgery just enough?
Yeah, so thanks, Mei Sze. So as an oncologist, the stagings of the cancers is very important, because that is sort of gives the oncologist the idea at what stage, what sort of treatments that needs to be given to the patients. So the staging here starts all the way from the initial assessments of the patients. So by doing so, with the imagings, by the clinical assessments, the surgeries, the outcome of surgeries, the reports, as an oncologist, we'll go through all these details, and finally comes down to the final staging of the tumor. So for someone that is talking about early stages, so stage 1. So stage 1, basically, surgery is the main modality of treatment. And stage 1, patients doesn't require, with a good surgery, the patients do not need or require an so-called adjuvant chemotherapy. Now, as the stage goes up, stage 2 and stage 3, this is where things will get a little bit more complicated, because we know that, based on the evidence that we have learned, that in stage 2, by just doing a surgery alone, the chance of the
Recurrence.
cancer relapse is actually now has gone a little higher compared to stage 1. And of course, in stage 3, this risk of recurrence in 5 years after surgery alone can reach up to as much as 50 to 60%. So in these circumstances, the oncologist will sit down to the patient and explain about the final reports from the surgery that's been done, and will discuss with the patients about the role of chemotherapy. So at this point of time, I think in the early stages, chemotherapy still plays an important role in terms of treatment. So for someone that is diagnosed with stage 2 and 3, the oncologist will discuss with the patients on the reasons of doing such treatments. Basically, you wanted to achieve a potential cure here. You want to kill any microscopic potential cancer cells that still remains behind, and you want to increase the chance of, from avoiding these cancers from relapsing. Yeah. So that is the part about early stages. Then, of course, when we talk about the more advanced disease, that is the part whereby things will get even more complicated because of the systemic therapies, which will become the main treatment modalities. Yeah.
Okay, so we'll talk more about that in a bit. So back to you, Dr. Qureshi. I think removing parts of the colon, like you mentioned, surgery is a part of the treatment.
Yes.
So it's a big surgery. I mean, I know I've been through colon resection. So what are the types of surgical approaches and perhaps minimal surgery for people who want to recover faster?
Sure. Okay. So as far as surgery is concerned, now there are basically we can divide this into open surgery.
Yeah.
Okay, and then we can divide it into keyhole surgery.
Laparoscopy.
Now, so keyhole surgery is then subdivided into laparoscopic surgery and also robotic surgery.
Yeah.
And there is an additional approach which we also do employ, and that is transanal excision of tumors. Okay, so just to get the transanal out of the way, transanal is where some patients, okay, they may say after a course of chemoradiotherapy, the tumor shrinks to quite a significant amount. It's very close to the sphincters, and we do a transanal, which means without going through the abdomen, so we through the anus we just resect a good margin. It's very similar to laparoscopic surgery, but instead of the surgeon being next to the patient operating, okay, he's sitting at a desk further away, and it's like playing a computer game on a screen, whereas the patient is away from you. So, but it is basically through small incisions. And now, as far as recovery is concerned, keyhole surgery, particularly laparoscopic and robotic surgery, the hospital stay is shorter, probably by about 1 day.
Okay.
Right? Yes. So you do have, the hospital stay is reduced. In terms of the operating time, keyhole surgery does tend to take a little bit longer. And in terms of recovery, that is for the bowels to function and get back to normal, it's very similar. Okay, and in terms of cancer clearance, for colon cancer, it's very similar. For rectal cancer, there is some evidence that perhaps open surgery is still superior. Okay, although the difference is small. But having said that, it really doesn't matter whether you have open, laparoscopic, or robotic surgery. What you want is to choose a surgeon who's competent.
Yeah.
Okay, so for colorectal cancer, whilst it can be done by general surgeons, you will find that results from colorectal surgeons are better. Okay, primarily because these colorectal surgeons are so boring. That's all they do, and so they do get better results. So it's more important to choose a competent surgeon, okay, rather than focusing on the type of surgery.
I agree.
Yeah.
Okay, thanks, Dr. Qureshi, for the explanation. I think I'll follow up with the question: Are there potential cases whereby there further therapy is not warranted after surgery?
Not warranted after surgery. I think these questions really depends on, as I mentioned earlier, the stage of the tumors. And of course, there are circumstances whereby that it also depends on the patient factors as well. So if you are looking at at what stage it is and at what age the patient is being diagnosed with colon cancer, let me just give you one good example. Would be for someone that is at the age of 80 years old, then was found to have a stage 2 colon cancers. In these circumstances, a lot of time you really need to have a in-depth discussions with the patient, not just the patients but also the family members. You need to take into consideration of any red flags from the final reports. If there is none, of course, it is safe to say that in these circumstances, some patients at this kind of age, the benefit of chemotherapy treatment is much lesser. Yeah. Okay. But as the disease stage goes higher and higher, then sometimes you really need to discuss. But perhaps in terms of the treatments, can always be adjusted accordingly to the patient's need. Yeah.
So it's based on the age, for example, and also, of course, the staging.
Yeah.
So these two factors are very important.
Correct. And sometimes you also need to take into considerations of patients' some other forms of medical illnesses.
Okay.
That will also potentially prohibit the patients from undergoing the ideal systemic treatment they're supposed to receive.
Okay. So when it comes to observation, like what type of surveillance methods in general for colorectal patient, and how does it help them?
Yeah, so based on the current international guidelines, in terms of monitorings, for stage 1, after surgeries, the follow-ups remains the same for the first 2 years. I will always follow up patients every 3 to 4 months. Get a physical examination on the patients, knowing how the patients are doing. I will do some tumor markers. So tumor markers is not 100% specific or accurate, but because there are cases whereby if, let's say, they have a tumor marker that was raised, then it becomes a very good tool to monitor. Okay, so in stage 1, truly you don't even really need to do any additional imaging scans per se, but you can consider things like a very simple like chest x-rays, ultrasound. As the disease becomes more advanced at stage 2, then you may want to potentially consider supplement with imaging scan, but I would not recommend it to be done on a very frequent basis. The current guidelines actually recommends it will be at most once a year if there's a need. Anything that's less than that is not really a mandatory or encouraged. So yeah, so in terms of monitoring here will include knowing the patients, how they are doing, physical examinations, some blood tests, and of course with the imagings. Now there are also new technologies that now being discovered. So one of these is what we call as the ctDNA. So ctDNA stands for the circulating tumor DNA. Basically, what happens is that when you have a cancer that in the body, sometimes they release these DNA cells in the blood. So ctDNA is a method whereby it's a non-invasive. You draw the blood, take a sample. So if there is presence of this molecular cancer DNAs that is present, it sort of gives you some kind of DNA fingerprint to tell you that there are existence of these cancer cells that still exist. So this ctDNA is emerging technologies. it's not being used as a standard of care at this moment, but in clinical trials and also in the companies are also start producing these tools to be used for those who would like to know more about their cancer disease, whether it's recurred, and it also can help in terms of the treatment decisions, whether chemotherapy is necessary or not, especially in a case, for example, like in stage 2. Yeah. So it can be used as a decision making as well as monitoring tools. So it's something that is new, and I got a feeling is that these technologies potentially might become one part of the colorectal cancer guide treatments in the future.
Wow.
Yeah.
So funny thing, we talked about ctDNA last episode with one of the companies that's doing ctDNA.
Right.
So yeah, they were testing for ctDNA, and it's also to kind of help determine treatment. So it's more like personalized medicine. I think that's something new that's coming along in terms of cancer advancement. So thanks, Dr. Jenson, for actually mentioning that and sharing that. I think more for Dr. Qureshi now, what are the challenges you often face when someone actually requires surgery for colorectal cancer? Yeah.
Okay. See, once a patient has been diagnosed with colorectal cancer, it's a life-changing, a time in their life, and it becomes very stressful. Okay, because that lots of things that go through your mind. Like for example, am I going to die because of this? Has it spread? Should I do the operation like tomorrow? Because the longer I wait, the more likely it's going to spread. What's going to happen to my family? I've got a job. I don't know whether I can take the time off. And when I do take the time off, what's going to happen? How long am I going to be out for? Am I going to have a colostomy bag? And how am I going to manage? So a lot of things what I do is that I go through very slowly with the patients about the diagnosis, okay, what it means, okay, what's to expect. For example, what to expect from surgery, what to expect immediately post-surgery, the risk of having a bag, a colostomy bag, okay, will it be temporary or will it be permanent? Okay, the length of time they're going to be out from work, okay, and so all of these factors need to be discussed in detail with the patient, and it's something that must not be rushed, okay. The patient must be given the time, okay, to understand what's happening, and in the vast majority of cases, okay, they do not need a colostomy bag for the rest of their life. If at the very worst, they may end up with a temporary bag. Okay, and we are currently in a situation where we have the ability to diagnose these cancers early. We have the ability to remove these cancers. We have the ability to prevent future cancers. Okay, and even if you have spread of the cancer, it's not a death sentence, okay? Because my friend here, Jenson, has got a huge amount of, armor to hit the cancer.
So that actually just sharing, that was me. Maybe because I was 27, my surgeon was trying to explain to me how it works. I briefly heard colostomy bag. I don't even know what it was. I rushed him through it, and I was like, okay, let's get it done. When are we going to get the surgery done? That was me.
Yes.
But maybe because I was young, I don't even know what it was, what this surgery entailed. But I agree that it's a life-changing diagnosis, and that people should really take time to understand what the surgery entails.
Precisely,
I think that's very important.
Yeah.
Don't be like me. Don't rush through it.
So it's very important because there are some patients who will say, look, I want the surgery now, as in, can you do it tomorrow? It really doesn't matter if you wait a week or two, and I think it's probably better if you do wait, Okay, because it allows
The mental prep.
yes, mental prep as well.
Yeah.
I think that's very important.
I didn't know what I was going into, and I woke up with a cold stomach like, what is this? Yeah, but it was temporary.
Yes.
It's gone now. Yeah. So back to you, Dr. Jenson. What's the outlook looking like nowadays for people who are diagnosed with colorectal cancer compared to 20, 30 years ago?
Yeah, so like what Dr. Krishu has explained earlier, nowadays when you talk about systemic treatments for colon cancers, right, we have a big load of treatment arsenals that we can actually, explore. And also in terms of the treatment can also be more personalized for the patients. So let me just wanted to give you an idea about, in the case whereby when someone is being diagnosed with an advanced colon cancer, for example, like a stage 4. Now, often not, I always will touch three things in the clinic. And the discussion is going to be a long one. So first and foremost, of course, never to ignore things like chemotherapy. So chemotherapy still remains important up to nowadays, even though now we say that we have other more specific targetable drugs that can be used. So chemotherapy still remains the backbone in terms of cancer treatment, colon cancer treatments. So what chemotherapy is all about? Basically, it's anti-cancer drugs that is administered in the body, and it will either kill the cancer cells or it slow down the growth of the cancer cells. So chemotherapies, for those viewers out there that being diagnosed colon cancers, you probably may hear some acronyms, common acronyms like CAPOX, FOLFOX, FOLFIRI, etc.
Yeah.
So that's the purpose of chemotherapy. Then we talk about targeted therapies. So targeted therapies are basically specific drugs that is being designed in such a way that it targets a specific molecules in the cancer cells. So by doing so, it gives you a more specific treatments directly to that particular cancer cells from dividing. So in another way is that it also helps to reduce or fewer side effects compared to chemotherapy. So targeted therapy is another form of treatment that generally it is used in combination with chemotherapy. Now, in order to do so, a lot of times you need to do something called a molecular testing, so-called the NGS. So next generation sequencing. So sometimes what I do is that when I see the patients and I feel, okay, this patient needs to do this molecule testing, I say I need to do a profiling of the tumor, which means that the samples of tumor will need to be sent to the lab to further study to identify what type of targeted therapies that can be used for that particular patients. Then of course the third one nowadays, the new kicks on the block will be the immunotherapy. So immunotherapy is something that is not new in terms of other cancer treatments, but in colorectal cancers we have also discovered that for a small subset of patients that diagnosed with colon cancers, there is something called the MSI, microsatellite instability, which means that these patients has the potential of using immunotherapy. So what immunotherapy is all about? So immunotherapy is also another biological drugs that is engineered in such a way that it harnesses the body immune systems to attack the cancer cells. So what happens is that in the body, our immune system somehow they are unable to differentiate before giving this immunotherapy. But once you introduce the immunotherapy for those patients that is deemed suitable, then the body immune system started to recognize that these cancer cells are something that is not normal and it's not attacking. So immunotherapy is something that is really a remarkable treatments for colon cancer for a small subset of patients. And I would like to share stories about how this immunotherapy worked wonderfully, especially in the rectal cancers over the last 5 years, when there's actually a studies that came out and says that for someone diagnosed with rectal cancer with MSI positive, by just doing immunotherapy, the patients can achieve 100% complete response, meaning that there's no surgery required, there's no radiation required, there's no chemotherapy required. And the studies is still ongoing, and so far 100% of patients are showing good response without evidence of disease. Yeah.
So that's amazing in terms of hope and healing and the modern advances to colorectal cancer.
Absolutely, yeah.
I'm going to ask my last question now to the audience. You can start putting in your questions now. So please ask any questions that you want in terms of colorectal surgery or colorectal cancer, colon or rectum. We have two esteemed doctors here that are more than willing to answer the questions that you have. So, Dr. Qureshi, in some cases, when colon cancer is considered advanced, stage 4 of course, and it has spread, is there still a role for you as a surgeon to step in?
Right. Okay. So essentially in stage 4, we are looking primarily to make sure that the patient has the best quality of life. So there may be some patients with a very small tumor, okay, but with spread to liver and lungs and elsewhere. Now, these patients, even though surgery is possible, but may not benefit the patient. So in those patients, perhaps, surgery should be, avoided. But then there are patients where perhaps the tumor is either bleeding or it's almost causing an obstruction. Despite the fact that they have stage 4 disease, surgery may benefit them because it will give them a better quality of life. So each patient, okay, is evaluated, holistically, and we make a decision based on that. So it's really what's best for the patient, not what's best for the oncologist or the surgeon, and that's how the patient should be approached.
Thank you. Thanks for that, assurance to patients out there. My last question is to Dr. Jenson. I think you mentioned about stage 4 earlier, and it can sometimes be complicated. So is there anything you would like, because we are talking about hope and healing for colorectal cancer patients, is there anything you would like to share with the audience, especially for those who were diagnosed with advanced stages of colorectal cancer?
Right. So I would like to add on further to what Dr. Qureshi has mentioned about in the advanced disease, where when we say that in stage 4, not all stage 4s are the same. There are cases whereby stage 4s, whereby the disease spread to the distant organs are limited. And there are also cases whereby because of the treatment that now currently available, we are actually looking at a much higher response in those patients. So in terms of role of surgery here, it's not completely, it's all lost. There are cases whereby that by giving a systemic therapies or chemotherapies with targeted therapies, or in circumstances whereby immunotherapies come into play, these patients, if they achieve a very good response, potentially these patients still have the chance of going through a curative surgeries, which means that removal of the primary tumor from the colon, as well as depending on the tumor site. For example, it's very common that we see in colon cancers the tumor spreads to the liver or to the lungs. But if the disease are limited, means that there are not that many tumor spread to these areas. Potentially, these patients still can undergo a curative surgery, which means that removal of the primary from the colons, as well as some part of the liver resections or the lung resections. So we are still, as oncologists, still always try to aim for achieve a potential cure in these patients. So, like I said, all hopes are not lost. There are treatments that is available. The only thing is that we just have to find out exactly what kind of treatment is the specific for that particular patients and how we can personalize the treatment. And I believe that all treatments can be, tailored accordingly. Yeah.
Thank you so much to both Dr. Qureshi and Dr. Jenson. I think today we are here to address colorectal cancer as a whole for those patients who are currently undergoing treatment and who are recently diagnosed. And we want to let you know that there's hope out there because there's so much modern advancement in terms of technology for treatment. So the most important part is to equip yourself with the right information and the right doctors, the knowledge that you need when you are diagnosed. And that's why we have Talking Life with Mei Sze. And now I'm going to start taking questions. So if you have questions, you can put them in now. I have one question. I think it's about a home pharmacy test kit. So recently, Madam Yo saw a pharmacy selling a home test kit for testing of colorectal cancer using stool.
Yes.
How would you say is accurate? How would you say this type of test, the accuracy of the test?
So really, we're talking about screening tests. Okay, so screening test is basically using a test to try and identify the cancer in the population at large. We can essentially divide screening tests into 3 different types. One is a stool test, second would be a blood test, and the third would be some sort of an imaging test. So a stool test, the oldest one is the FOBT. So that's fecal occult blood testing. So that looks for blood in the stool. Now, this test is or really was so sensitive that even if you say if you had a beef the night before, okay, and you tested it the next day, might prove positive. Or if you brushed your teeth very hard, a tiny little bit of blood can still be detected. So then they developed this FIT, which is the fecal immunochemical testing, and that avoids the need for dietary restriction and tends to be more accurate. Okay, and of course there are newer fecal tests which look at specific antibodies and the hemoglobin in the blood, although they're not as commonly available. So the FOBT and the FIT are the most common. Blood tests generally not as good, particularly things like tumor markers. The specificity and accuracy is in the region of about 30 to 31%, so really poor. And in fact, people with lung disease, kidney disease, smokers have abnormally raised tumor markers, and that again sways it. Imaging tests would be things like, for example, colonoscopy, CT colonoscopy, or even a barium meal. So of course colonoscopy is the gold standard, but unfortunately it is more expensive, and you need a bowel prep, which, as you know, is not really the most pleasant thing to take, and it requires sedation, and it of course has got risk. So as far as the fecal tests are concerned, they are generally used for the population at large, and there are some countries like Australia where everybody over the age of 50 is sent one of these kits, on maybe 2 to 3 yearly basis, and then and if that's positive, then they're invited to have a colonoscopy done.
Okay, so I think the next question is, I'll take this one, is, doctor, for a patient with low rectal tumor and MRI showing mesorectal fascia involvement, would you recommend neoadjuvant therapy before surgery, or is primary resection an option?
Yeah, so
I think
this
for
is
you.
something that we discuss all the time. I discuss it with him, and normally we will look at the pictures together with the radiologist, and in the vast majority of these cases, they will we would send them for neoadjuvant. The question is really whether they need a short course or a long course. That's really more the question, rather than should they have it. And in general, I think one of my Korean colleagues not too long ago, said that you can divide the tumors into the good, the bad, and the ugly. Okay, the good ones, they have surgery. Bad ones, they get the short course, and the ugly, they get the long course. So these are the ones that are much larger. Perhaps they are infiltrating the bladder or other parts, and they need a reduction in size. They tend to get the long course.
We hope that answers your question, Ika. I think the next question is, I think it's for you, Dr. Qureshi. If a patient is wearing a colostomy bag for life, is there any hope or new technology to reverse it? Perhaps reconstructing a makeshift?
Yes. Okay. So the simple answer is yes. Okay. Now, unfortunately, it is quite a complex and highly specialized surgical procedure where as long as the patient is cancer-free, there is the possibility, okay, of reconstructing an anal sphincter using one of our thigh muscles here, the gracilis. Okay, so it's a very long muscle. So we release it from the knee and dissect it off, and then we encircle it around where the anal sphincter was. So it can be done, but it requires multiple procedures. It requires a pacemaker for that muscle itself, okay? And it can be quite technically demanding. There are artificial sphincters, okay? Again, they have been used, but the availability of this is the main issue, and they are very costly.
Is it available in Malaysia?
Not at the present. Okay, the gracilis muscle reconstruction is available, but the artificial sphincters, I don't know of anybody else who does it. Yeah.
Okay, thanks, Dr. Qureshi. I will take one last question.
Lisa, if you may, I would like to add on about the earlier question about the maxillorectal fascia, right?
Okay.
I think that is a very, very, very important question because in these circumstances, like what Dr. Qureshi mentioned, it's always about doctors, surgeons, and also oncologists to sit down, to go through the case, to look at the imagings. In general, I would say when there is a maxillorectal fascia is involved, this maxillorectal fascia is the part whereby the surgeons need to have a good clearance in order to prevent a local recurrence. So when it is threatened or it is involved, in these circumstances, a pre-operative treatment needs to be delivered. And in these circumstances, we're often talking about radiation therapies. So it's something that needs to be discussed, of course, about short course and long course. If it's a fascia that is already threatened or involved, then in these circumstances, we're talking about long course will be the ideal way of downsizing the tumors. That is the gist of it. Yeah.
Okay. Thanks, Dr. Jenson. I think I'll take one last question from Rennie. Hi doctors, how to differentiate between IBS, basically inflammatory bowel disease, and early stage colorectal cancer? Is it through an endoscopic evaluation?
Okay, sorry, IBS?
IBD.
IBD, sorry.
Yeah.
Okay, right. Okay, right. Okay, so IBD is basically an inflammatory bowel condition. So primarily, it can be either ulcerative colitis or Crohn's colitis. Now, these patients are at risk of developing cancer in the long run. Okay, so if the disease is mild, the risk is lower. If the disease involves only a small segment, the risk is lower. So that in itself will give you some indication as to the risk of that patient. Of course, as to how long the disease has been present is also very important. So in order to identify the symptoms of these two, you're absolutely right. A colonoscopy is by far the most accurate. Okay. And as we were discussing just before we started, colonoscopy has developed over the years, and the most recent introduction for colonoscopy is artificial intelligence, where as the scope is being performed, okay, the AI is monitoring the surface, okay, of the colon for tiny little polyps, and sometimes these polyps are not very obvious until the AI tells you, look, there might be something there. So it is, very important to have that done, particularly if you've got IBD. Colonoscopy on a regular basis may be warranted. And sometimes you may find that the endoscopist takes random biopsies, not just of any random biopsies, particularly in ulcerative colitis, because if the patient develops what we call change, not quite cancer, but changes that are heading towards cancer, then they may need surgery before it becomes cancer.
That's very interesting. I've actually known of a case like that. So in the end, they actually did the surgery, but it was kind of like preemptive surgery as well.
Precisely, yes.
So thanks for sharing that, Dr. Qureshi. That wraps up today's episode of Talking Life with Mei Sze. I'm sorry we cannot take all of your questions today. And I think thank you so much to Dr. Jenson for continuously coming back on the show. He's a clinical oncologist with Curie Oncology. And thank you, Dr. Aktbar Qureshi, who is a colorectal surgeon with St. John Medical. And thank you all of you for staying tuned tonight. Remember to share this live with your friends and family so they can watch during their free time. And for the next few episodes, I have yet to set the date, but I plan to talk about genetic mutations such as BRCA1 and BRCA2. So we want to understand more about that and how it actually relates to cancer. I think many of you have questions about that. So I want to dive more into that topic in the next coming episodes. See you soon. And for those of my Muslim viewers, Salam Ramadan and Selamat Hari Raya in advance. Thank you. Bye.